Hello, everyone. Welcome back to The Truth About Liver Cancer. This workshop today is produced by Blue Fairy, the Adrian Wilson Liver Cancer Association. A nonprofit organization, Blue Fairy's mission is to prevent, treat, and cure primary liver cancer, specifically hepatocellular carcinoma, HCC. Remember that, you're going to be hearing that a lot, through research, education, and advocacy. For those who are here with us already, if you can just give me a thumbs up in the chat and let me know that you can hear me and that you can see me. As far as I know, we are live. Today's workshop focuses on meeting your multidisciplinary team. Now, this topic is so complex that we created 2 workshops. Today, we will meet doctors who focus on liver disease and cancer, including gastroenterologist, hepatologist, and transplant hepatologist. In June, we will meet doctors who focus on liver cancer, specifically medical oncologists who do specialize in HCC. And even with all of those doctors, that's still a sliver of your multidisciplinary team, and we'll dive into that topic. Today's workshop is sponsored by AstraZeneca, and we thank them for their support. And I often forget to introduce myself, so if you don't know me, my name is Andrea Wilson Woods. I'm the president and founder of Blue Fairy. I started the organization in honor and memory of my sister Adrian, whom I raised in my 20s. I raised her from the time she was 8 until she died from HCC at the age of 15. Now, that was over 20 years ago, and we have come a really long way. And before we bring our first person up to the stage, I want to show you a poll. So if you'll look at the bottom, there should be a little pop-up notification. Please make sure pop-ups are available on your computer. So this poll we have is, what's your relationship to HCC? We just want to know, are you a current patient perhaps, or a current caregiver of a patient? Are you a survivor? And yes, we are going to have a survivor workshop later this year. Are you a caregiver for a loved one, or were you? Are you a medical provider who sees HCC patients? So I'm going to leave that poll up for just a bit and talk about this platform. So this is a very interactive platform. So we highly encourage you to talk to each other in the chat. However, if you have a question, we want you to put it in the Q&A. So if you look at the bottom of your screen, you should see a little ask a question. And if you click on that, it doesn't look like a button, but it does open. If you click on that, you will see questions that some people asked even before we went live. And you can upvote a question. So let's say someone has already asked the question that you really wanted to ask. We'll just give them an upvote, and that question will move to the top. So we will be doing Q&A at the top of the hour, so please stick around. And as a reminder, the physicians today cannot give personal medical advice. They will do the best they can to answer your questions. And if you would like to follow up with any of them after this workshop is over, we will make sure that my email is put in the chat so we can make that happen for you. So again, let's take a look at the poll, see how we're doing with the poll here. All right. Oh, we have some current patients, current caregivers of patients, medical providers, and some in the other. All right, I'm going to leave that poll visible for a couple of more minutes, and let's jump right in. So we're going to bring Dr. Andrew Moon to the stage. Of course, I have to find him to be able to do that. A little tricky as I'm navigating them. So we're going to invite Dr. Andrew Moon to the stage right now. Dr. Moon is a hepatologist at the University of North Carolina, and he is part of the UNC Multidisciplinary HCC Clinic. Dr. Moon has research interest including the prevention of liver cancer with improved surveillance, the comparative effectiveness of local regional therapies, the role of patient preferences in HCC treatment decisions, very exciting, and patient-reported outcomes. Dr. Moon, welcome.
Thank you so much.
Oh, we're so thrilled to have you.
I'm thrilled to be here.
Yeah, so I'm going to ask you a question that I'm going to ask all the doctors today.
Okay.
Did you always want to be a doctor?
It's a good question. The short answer is no. So I grew up in a a household of healthcare providers. My dad was a physician. He's a anesthesiologist. My mom's a nurse. So I was hearing all their stories about the hospital and the clinic when they came home for dinner. And I told myself, no way I'm going to be a doctor or be in healthcare. I'm going to be a rebel and do something else. So I explored journalism. I got a marketing degree in college. And during college, I took a course as part of my psychology minor. It was called the physiology of psychology. So it was all about the neurology and anatomy behind some psychological disorders. And I found it so fascinating. So I said, okay, well, maybe this medicine thing is kind of cool. And so started volunteering at the hospital, got a chance to interact with patients, and I was sold at that point. So the rest is history.
You started volunteering as an undergrad?
I did, yeah.
Wow. Oh, that's so cool. I don't think enough students do that these days. Well, why did you go into GI and hepatology? How did that happen?
Yeah. So during medical school, I found the GI and hepatology, the medicine and behind it and the science behind it to be really interesting. And once I got the chance to be on wards, I did a GI block and just found it really satisfying that we could see a patient who had an issue and oftentimes, be able to do an upper endoscopy to figure out what was going on. And so new GI and hepatology were both of interest and really got interested specifically in hepatology and HCC when I was a medical resident. So I was at the University of Washington in Seattle and had a research mentor at the Seattle VA who worked on big database research with the Veterans Affairs system. So got to work on a few projects in liver cancer and cirrhosis using that national cirrhosis database. So got incredibly interested in that sort of research and knew from then on that I wanted to do hepatology and HCC.
You mentioned cirrhosis. So could you define that for this audience and then tell us what are some other common symptoms of liver cancer?
Yeah, so cirrhosis is essentially a condition where some chronic liver disease leads to a lot of scarring in the liver. So the most common cause of chronic liver disease are non-alcoholic fatty liver disease, alcohol-associated liver disease, hepatitis B, and hepatitis C. There are some other rare causes, but those are the most common things. Over years and years, those conditions will cause inflammation or irritation of the liver. And the liver is really good at healing itself up. But that process of damage and repair over time leads to a lot of scar tissue. So cirrhosis is essentially just a really, really scarred up liver. And there can be kind of two sets of issues that come about as a result of that. So as a result of the scar, the liver cells themselves don't work as well. And the liver cells do a ton of different things for your body. And then the blood flow through the big vein, the portal vein, can be sluggish as a result of all that scar tissue. And so you can get complications of portal hypertension. And that could include things like fluid in the belly, ascites, toxin buildup, hepatic encephalopathy, or enlarged blood vessels in the esophagus that can burst and bleed, and that's variceal bleeding. So some of the most common symptoms are related to those complications of portal hypertension. So some patients say, yeah, I've been getting some swelling in my legs or my belly, or I'm not thinking quite as clearly as a result of the toxin buildup. And then some of the other common symptoms we deal with is things like itching and cramping, fatigue, sometimes abdominal pain.
I'm so glad you mentioned itching because I know of a patient who was itching for a year so severely that his skin was raw because he was just scraping his skin off, doing it at night. And it just kept getting written off as allergies. And it took a year of living in that misery to finally get a correct diagnosis of HCC. And no time during that year was any sort of blood work done that could have given them an indication that something was wrong with his liver. And at the time, that was really the only symptom he had was this extreme itching, but it lasted a year. So don't want people to panic, though. Just because you're itching doesn't mean you have liver disease or liver cancer, but it's definitely a symptom. What is your favorite part of your job?
Yeah, so there are a lot of things I love about my job. I just love, as a physician researcher, I have quite a bit of variety in my schedule. And so I'll be in the clinic on Monday, and then, we have talk about liver transplant selection on Wednesdays. I do some endoscopy on Thursdays, and then Friday I have my multidisciplinary HCC clinic, which I love. Definitely the favorite part of my job and the days I like the most are the days when I have time to sit down with patients and families to discuss their illness, answer all their questions, and really take time to have a in-depth conversation about what's going on right now, how we're going to address it, and what the future may hold. So those kind of sit-down discussions are by far the most worthwhile part of my job.
And when you see a patient with HCC, since we do have some transplant hepatologists coming on, how often are they eligible for a transplant or even downstageable?
Yeah, so it's a great question. It's something I always think about. So I'm the hepatologist in our multidisciplinary clinic, which includes, oncologists, interventional radiologists, radiation oncologists, and surgeons. And it's one of the things that's always at the forefront of my mind when somebody comes in with a new diagnosis of HCC. Is liver transplant something that makes sense for them? Is it a possible option? Is it something they may be interested in? And so we're always thinking about it. And there are patients we are able to downstage. There are patients who are within what's called our Milan criteria, which is the criteria for liver transplant, who we can get to liver transplant. The reality is the minority of patients who present with liver cancer end up with a liver transplant. I think the most recent data that I've seen are, if you have localized disease, about 25% end up with a liver transplant within the next 5 years. Overall, it's closer to 10%. And that's partially because of the stage of their liver cancer. So,
Right.
it's not possible if the liver cancer spread beyond the liver, for instance, and wouldn't be wise to do a liver transplant in that situation. But it's oftentimes the non-liver related issues. So other medical comorbidities, if they're sick from things other than their liver, lacking social support, ongoing alcohol use. And unfortunately, lack of insurance is a big issue, particularly in North Carolina.
Yeah. Oh my goodness. I want to circle back to something you said. I know that you really enjoy research as well. And can you tell us what is it about research that you like?
Yeah, so research is incredibly valuable because it, allows me the opportunity to work with folks like Dr. Singal and Pillai, who you'll hear from later. So some of the giants of the field, I get the chance to collaborate and learn from them. But on a day-to-day basis, it's really I'm constantly curious and thinking about new questions, and patients are coming in and asking good questions or raising issues that I don't think I have a good answer to. And so oftentimes, whether it's a patient asking a question or one of the medical students on service with us, we'll go to the literature and see if there's a good answer to that question. And oftentimes there isn't. And so that's a good opportunity to say, is this something we could potentially research? So it allows you to take unanswered questions that you come across in clinical care on a daily basis, and allows you to study those to hopefully come up with a good answer to that. So it's kind of like on a day-to-day basis, helping patients and getting them the treatments they need is incredibly valuable. But on the kind of longer term, being able to perform research and answering those bigger questions is also very satisfying.
One last question before we bring our next panelist up. What are those bigger questions? You just said bigger questions. What are they in your mind?
Yeah, so I think there are a number of questions in liver cancer, and it comes from everything to, there are a lot of risk factors we know about liver cancer. We know about, the common risk factors: chronic liver disease, non-alcoholic fatty liver disease, alcohol-associated liver disease, viral hepatitis. But what about environmental risk factors? I think we need to learn more about that. Something that, I'm sure Dr. Singal will bring up is how do we improve our surveillance tools? How do we better detect HCC at an early stage so more patients can get cured? And then a lot of people are working on things like HCC treatments and how do we improve those? And as you had mentioned, part of my research is trying to figure out, how patient preferences may fit into that. And so how do we kind of address and prevent some of the post-treatment symptoms and liver-related decompensations that are so common?
Well, thank you so much for setting us up, for going first. If you have any questions for Dr. Moon, he will be here at the top of the hour to answer your questions. So Dr. Moon, we will see you in just a bit. So please stand by. And we are going to bring Dr. Jody Olson to the stage. Now, Dr. Olson received his degree in medicine from the University of Nebraska College of Medicine in Omaha, Nebraska. After his residency in internal medicine at the University of Minnesota School of Medicine in Minneapolis, he completed fellowships in critical care medicine and transplant hepatology at the Mayo School of Graduate Medicine in Rochester, Minnesota. Dr. Olson's research experience has included studies of acute and chronic liver failure and liver transplantation. He has presented at a number of congresses, and if you're not familiar with that word, it's jargon for conferences or events. He's contributed to book chapters and has published several peer-reviewed articles. He's currently a senior associate consultant at the Mayo Clinic in Rochester, Minnesota, in transplant hepatology. Welcome, Dr. Olson. How are you today?
I'm very good. I'm excited to be here. Thank you.
All right. I'm going to start with the same question. Did you always want to be a doctor?
No, not even close. So I didn't have anybody in my family that had even gone to college before me. I went to college thinking I wanted to be an attorney, and I had a very wise advisor who had me major in science, even in case I wanted to change my mind a little later on down the road, and that probably opened the door for me to make some better decisions later on.
Wow, that's so interesting. And why an attorney? I'm just curious.
I think the television show LA Law was most popular when I was growing up in high school. That might have been what did it to me, and maybe I like to argue a little bit, but
I remember that show. Now, I know that you did pay your way through college in a medical sense. So what did
yeah.
you do to
Yeah, so I was a paramedic as as a way to pay my way through college. That's how I probably developed a stronger interest in medicine and moved forward in that regard. And my paramedic program advisor was also the pre-med advisor, which is what led me into a career in medicine later on.
Interesting. And did you always want to go into GI and hepatology?
No, in my med school years, I was for sure going to go into OB/GYN. It wasn't until the last possible minute that I changed my mind and veered off into internal medicine, which opened up a lot more doors for different interests. And that's ultimately what was my foundation before I went forward in liver disease.
Wow. Okay. And Dr. Moon set us up with some of the symptoms with liver disease and liver cancer. Can you tell us what is the difference between what is causing HCC now versus 10 years ago or even 20 years ago?
Yeah, so some of this still is dependent on where you are globally. Globally, viral hepatitis still is probably one of the leading causes of hepatocellular carcinoma development. But when you look in the United States, and also this landscape is changing everywhere. But after the advent of the most really shockingly effective treatments for hepatitis C, we've seen a
Yeah.
dramatic decrease in viral hepatitis as a cause of liver cancer in the United States and across the globe as well. And we also have more effective treatments for hepatitis B today. While we can't cure hepatitis B, we can certainly control this illness, and that has also resulted in a decrease in viral hepatitis associated liver cancer. But as Dr. Moon mentioned earlier, non alcoholic or metabolic associated liver disease has rapidly risen across the globe as the leading cause of liver test abnormalities, liver disease, and is also now an increasing cause for hepatocellular carcinoma.
So on that point, I just want to clarify for people, if you hear non-alcoholic fatty liver disease, the acronym for that is NAFLD. But a lot of doctors now just say fatty liver disease for simplicity. Um, what are some of the challenges when someone presents with liver disease, specifically with fatty liver?
So metabolic associated liver disease, I think most people will, have seen this. It's more common in people with type 2 diabetes, hypertension. You think about these patients that have other comorbidities like cardiac disease, and it's hard. It's not as simple as saying to somebody, exercise, control your diabetes, and lose weight. Non-alcoholic fatty liver disease, metabolic associated liver disease is really multifactorial. It has a genetic component, lifestyle components. And because it's such a challenge, it requires a lot of sustained effort and a diverse approach to attacking this problem. But it's not easy. It's not as simple as giving a single medication or a single treatment that can control, reverse, or get metabolic associated complications under control.
Wow. And, you know, I know we didn't prep this question, but I'm just curious your thoughts that there's a prediction that liver cancer will almost double in the next 20 years worldwide, and that we're going to go from about 800,000 new cases a year to 1.4 million new cases a year. What do you attribute that to, assuming that's true?
So I think the audience may not know this. So I think we see on TV all the time commercials for breast cancer, and there's other cancers that get a lot more attention. But if you look across the globe, hepatocellular carcinoma is the number three. Depends on which study you read, but let's say the
Yeah.
number three leading cause of death in the United States. It's either number five or number seven leading cause of death in men and women, respectively. So even though we've made headway in treatment of other types of liver disease, the fact of the matter is metabolic associated problems continue to rise significantly. You can sort of look at what's happened with the metabolic profile of people in the United States over the last several years, and this is it's a real epidemic. And so this is one of the drivers in why we're continuing to see an increased rise in primary liver cancer, in spite of having made some significant advances in treatments of some specific liver disorders that drive the development of hepatocellular carcinoma.
Wow. I want to go back to something Dr. Moon said so you can explain to the audience. He mentioned the Milan criteria. What is that for people who don't know?
So, as Dr. Moon had mentioned, we're always looking when we see somebody present with liver cancer, we're looking to determine if a patient may be a candidate for curative therapies.
Mm.
And typically, this still involves surgical resection or consideration of liver transplantation. Liver transplantation is only a tool that may be available to a patient if the disease is still localized to the liver, meaning it hasn't escaped and moved to other parts of the body. Through numerous studies, we've evaluated what are some of the criteria we can look at a patient just with imaging studies or biochemistry markers before you've done the transplant to determine if a patient is at high risk for having had liver cancer spread beyond the liver. So the Milan criteria have proven through pretty extensive research studies to be a reasonably reliable predictor of risk of extrahepatic spread, spread beyond the liver. So the Milan criteria currently, our patient can have up to 3 lesions in the liver that are hepatocellular carcinoma. And if they have 3, none of them can be larger than 3 centimeters, or a
Wow.
single lesion that's up to 5 centimeters. Now, this is what we typically use to say to stage risk. If you have 7 tumors in the liver, this is a marker that would suggest that you may have already had spread outside the liver, and that's why we use Milan criteria. Predominantly, there's also a secondary criteria that I won't go into too much detail, but known as UCSF criteria. And as Dr. Moon had pointed out, we're always looking to see if we can push the envelope a little bit further, but specifically, we're trying to utilize tools that we have before the patient undergoes transplant to predict post-transplant recurrence risk.
So Milan criteria is a measuring stick, if you will.
That's a great way to describe it, and it's fairly simple and objective.
Okay. And I want to talk to you a little bit about stigma. So one of the challenges that we have at Blue Fairy is the stigma that's often associated with liver cancer. But what type of stigma are you seeing today, if any?
I still think that liver disease in the general population isn't a popular topic. You don't see commercials about it very
It's
often,
true.
and so because of that, there's still a sort of a lack of education in the community about what causes liver disease. And so there's still a misconception that all liver disease is related to, alcohol or drug
Yeah.
abuse, which is just absolutely not the case. And so it's sort of a lack of foundation of knowledge and probably a lack of popularity for an illness that still results in this stigma. So when people are given a diagnosis of liver disease, they often, I think, fear that they're going to be labeled that way. And the other sort of frightening statistic, to Dr. Moon's point, that we're always trying to figure out ways to identify disease earlier.
Right.
An interesting study published from a journal from the University of Chicago demonstrated that approximately 60 to 70% of people that get a diagnosis of cirrhosis had no idea they had liver disease before they were found to have advanced stage problems. So it's still a disease that is not recognized early enough, which leads to you know sometimes the thing that people present with in advanced liver disease is hepatocellular carcinoma.
Do you think that's why, and I'm oversimplifying here, that people often don't know is because the liver doesn't have pain receptors?
Yes, because it's liver disease, liver inflammation. If you don't catch it with laboratory studies, may be 100% asymptomatic, and this can brew
Wow.
on for years and years and years. Even things like viral hepatitis B or C, you may never have had an obvious symptom when you were infected with one of these illnesses, and after you have an established infection, you may not have any symptoms. And so oftentimes people are not identified to have a underlying liver illness until it's really quite advanced.
Yeah, and I just want to reiterate that point with my sister when she was diagnosed. She was a 15-year-old Caucasian female. She was as far from the typical liver cancer patient at that time that you could get. But they did discover that my sister had chronic hepatitis B and hepatitis C that she had been living with her entire life, and we had no idea. And so, to your point, it can be incredibly asymptomatic.
All
Yeah.
major liver societies are, working on the hepatitis front to, increase global awareness of of these diseases and help people recognize them sooner. But it's going to be a problem for the foreseeable future because there's still a lot of viral hepatitis across the globe that is under-recognized.
Wow. One last question before we later bring you back for the Q&A. What I'm really excited about is I'm seeing more young people doing their residencies and post-grad work, and they seem to be a lot more excited about GI and hepatology. So what would you say to young people who are in medical school to try to sway them to get them over to this specialty?
Well, I always tell people that the liver is the most interesting organ of the body, but I'm a little bit biased. But I think I think that for people that are really really like managing complicated disease, really like working across multidisciplinary teams, and really like spending time with patients, liver disease is a great specialty. And you get to walk people through illness across a variety of different spectrums. Getting somebody through transplant is very exciting, but it's equally rewarding to be able to help somebody with an illness that can't be cured or treated, to learn about their disease, to understand it, and to help them manage it successfully and give them the best options. It's a great specialty. There's great people in the field. It's still a relatively small community, so a
It
lot of us
is.
know each other, and I think most of us think that the group is a pretty fun bunch of people to work with.
I would say so. Dr. Olson, thank you so much. If you have questions for Dr. Olson, please put them in the Ask the Question area. And so we are going to send you back to the audience, but please stick around for the Q&A at the top of the hour. And we are going to invite Dr. Singal to the stage. And before I introduce Dr. Singal, I just want to address, I see someone in the chat. Mari, I really appreciate your comment. The reason we do start off with a few personal questions is that sometimes I feel like doctors are not seen as humans. And so I just want everybody in this workshop to really get to know the doctors. Dr. Amit Singal is a professor of medicine at UT Southwestern Medical Center in Dallas, and he serves as the chief of hepatology and director of the liver tumor program. He has received NIH funding examining the HCC care continuum from screening to treatment and has over 200 publications. He is appointed as the Willis C. Madre, not sure I'm saying that right, Distinguished Chair in Liver Disease, and has been awarded the Blue Fairy Award for Excellence in Liver Cancer Research. Dr. Singal, thank you so much for joining us today.
Yeah, thanks for having me.
So what about you? Did you always want to be a doctor?
Well, I think you're probably going to sense a theme here. And so I also went through my time where I questioned if this was the career path for me. My dad was a physician, and so I saw that growing up, and I saw him coming home sometimes at 8 or 9, and I sort of in my younger years questioned if that was the right career path for me, and
Right.
I then thought about going into being a teacher or doing other career paths where I would still make a difference in the world, but just in a different way. And eventually came back to medicine. I think it was, it's a very sometimes difficult field, but it's so rewarding, and I think it's so unique in the difference you can make.
And why did you choose hepatology?
I think that, also somewhat of a circuitous route of how I got to hepatology. I initially had considered other fields and went into GI initially because of this possibility of acutely solving something and fixing somebody. So this idea of a person with GI bleeding, you do an endoscopy, you solve it, and that person goes home, the next day or 2 days later. But then the more I got exposed to hepatology, it was a field that is, as you've heard before, just fascinating. And the liver is a very unique organ. And for me, honestly, one of the biggest things was this idea that there was progress being made, but so much more to do. And so, as you already alluded to, my personal career involves a balance between doing clinical practice and doing a lot of research. And so it's a field that I felt like I could make a difference on a person-by-person basis when I do clinic, as well as contribute to sort of public health and broader advances in the field, via research.
Wow. When patients come to you for HCC, how do you determine who gets a transplant or more systemic treatment? So what is that sort of best therapy up front?
Yeah. So, the approach that I think that most of us take is thinking of what is the most aggressive curative approach possible.
Right.
So is there a way that we can offer cure for liver cancer? And when we think of this, I think many of us think of liver transplantation as being the best curative option, because it not only addresses the underlying liver cancer, but also that underlying cirrhosis.
Right.
And so, you've already heard about the Milan criteria. You've heard about some of these expanded criteria. This concept of presenting with larger tumor burden, responding to therapy, getting quote unquote downstaged to Milan criteria is something that is now happening routinely in clinical practice.
Would you explain that quickly, what downstaging means
Yeah,
in layman's terms?
Yeah, so, it's the type of thing where you present outside of the Milan criteria. So you present with more tumor than is, initially permitted by the Milan criteria. And you would treat somebody with local therapies like chemoembolization, where you inject beads embedded with chemotherapy, or radioembolization, beads embedded with radiation therapy into the liver. And if that cancer responds, this implies it has a good tumor biology. It has good prognosis. And so if you respond and you come to within Milan criteria, you can then undergo transplant with very good long-term outcomes, very similar to those people who initially started within Milan criteria. And as a field, this is fantastic, because what it means is we can offer cure to more and more people that were initially outside of those criteria and sort of not permitted routinely to undergo transplant. And so, I'll get to the initial question of like how I select, but, I have to say it's one of the toughest things when I see somebody who was seen in a non-transplant center. So somebody that was not thinking of transplant.
Right.
Initially presented either within Milan criteria or was downstage, and that wasn't considered. And by the time they consider transplant, it's when they're like, oh, my other therapies are failing. And at that point, then I'm like, the cancer's too big, or, there's other things that preclude transplant at that point. And so I think this is something where, to your point of how do you consider, I think one of the key things is to go to a center that really considers the entire spectrum of care.
Right.
And so, I think this idea of can we offer curative therapy, transplant, surgical resection is another very good therapy. If your liver's functioning well, you have limited tumor burden, you can often resect or cut out the disease and have good long-term outcomes, or you can ablate it, you can burn it, and once again have a very good response. Now, if you can't do those curative therapies, then we have these local or systemic therapies, the chemoembolization or radioembolization, those beads that are injected directly into the liver,
Right.
or immunotherapy, these systemic therapies that are well tolerated and can induce responses in, about 1/3 of people. So the good thing is we've seen tremendous advances across the entire spectrum. But as I said, I think the key thing is to really go to a center that considers that entire spectrum of treatment options.
I'm thinking of a couple and a patient who had surgery, was a good candidate for surgery for resection, and did not have underlying liver disease. In fact, the cause of his HCC was never known. But what was upsetting for him and his wife was they were not told how often HCC can come back.
Yeah.
So how often after transplant does HCC occur, in a healthy liver?
Yeah. So, that's one of the nice things with transplantation versus some of these other curative options is because you're removing that underlying cirrhosis, the risk of recurrence after transplant is around 10%, which is the lowest that we can get it.
Wow.
But once again, when you take a look at cancers across all cancers, we know that there's always a chance of recurrence, and 10% is actually fairly low when you consider this across, all of these different cancer types. Now, conversely, we talked about surgical resection, we talked about ablation, also cures for that initial cancer, but they don't treat the underlying liver disease. They leave behind that cirrhosis. And so to your point, the chance of recurrence is about 50 to 70% within 5 years after surgical resection or local ablation. Once again, because of a combination of that initial cancer coming back, or forming new tumors in the setting of your cirrhosis.
Wow.
Now, the positive news, we have wanted a therapy that can reduce that risk for years. And all we've had is negative trial after negative trial. But we just saw the first positive trial report out earlier this year, We're going to see it actually presented in full form this week. So it's the type of thing where we're making progress. And so now we have a therapy after surgical resection or local ablation that can significantly reduce your risk of recurrence.
Wow. Is it too early to share what that therapy is with us?
Yeah, no, so it's the combination of long names, but atezolizumab and bevacizumab. So the same systemic therapies that are now used in the advanced stage setting have now expanded out to earlier stages of disease.
Wow.
And so by using this systemic therapy, and it's typically given for about a year after the procedure, you can once again reduce that risk of recurrence.
Oh God, that's amazing. We're going to dive a little bit more into this in the panel Q&A, but one of the frustrations for patients is who's in charge.
Yeah.
So how is it determined who's in charge of this multidisciplinary team? You know, who's in charge?
Yeah, we throw a stick in the middle of the room, and whoever grabs it, that's no, I'm joking. Yeah, you know, so it's the type of thing where you're right. So this is lots of disciplines coming together that are discussing this. So, you know, you've already heard some of these disciplines mentioned, but you have hepatologists, typically transplant hepatologists, you have surgeons, interventional radiologists, medical oncologists, radiation oncologists. You have everyone here who can offer different things. And the nice thing is that we have evidence that shows multidisciplinary programs and multidisciplinary tumor boards, where you get all of these people in a room and you talk together, significantly improves outcomes. You have more curative options, you have better patient concordance and better patient communication, and most notably, you improve survival. So like, I think all of us agree multidisciplinary care is good. Now to your question, who actually runs that multidisciplinary team?
Yeah.
A multidisciplinary team is not a multidisciplinary team is not a multidisciplinary team. And so there's really large variation in terms of how these multidisciplinary teams are run and who's in charge. Ideally, and you know, this is ideal, is the person who runs that tumor board would be the person who is the best aware of that entire spectrum of HCC care. So is not just an expert in their own domain, but really understands what everyone can bring to the table and can thereby engage them to ask them, for this individual patient, what can you offer? Now, in my personal opinion, and I'm biased because this is where I reside, I often think of a hepatologist as being that specific person who can often run that tumor board, and do so because the common theme across all of these different treatment options is underlying liver disease, and the impact of underlying liver disease on what therapies are eligible and what therapies would offer the best prognosis. And so I think a transplant hepatologist can typically, once again, understand that component of liver disease, which is central to all HCC care, as well as, once again, understand that spectrum of who to involve in different discussions, not only at initial presentation, but as somebody progresses through their care, either responding to therapy or progressing on therapy, and thereby needing to sometimes switch therapies from one to the other.
Wow. So it varies, is what you're saying.
Yeah, it does. It does. And of course, I'm biased in terms of, but you will see, once again, I think the key thing is expertise. And so even though it varies, I would hope that the person running that tumor board is the one who best understands HCC in that local community.
Yeah, it's so critical to not only get a second opinion, but make sure you're being seen by someone who understands this disease inside and out. It's so critical. I want to ask you one last question before we bring Dr. Pillai up. So can you explain what UNOS is, UNOS, and the recent policy change that has happened regarding liver transplants?
Yeah, so UNOS is our national organization that really regulates organ sharing. So we know that, you know, unfortunately, there are more people who need a liver transplantation than can currently receive a liver transplant. And so there is a national organization that is responsible for organ sharing and allocation, as well as some of the policies on where different diseases fall on that list. Now, in general, the entire policy is driven by the sicker you are, the more urgent the transplant is, and the higher you are on that list. So it's not a waiting time game, it's how sick you are. And so I think that's the first thing that I think we have to understand, that this is all based on the correct ethical principles of, giving the greatest demand to the entire population of patients that need a liver transplant. Of course, great principle. In terms of enacting it, it's much more difficult to do, particularly when you consider the fact that the United States is a large country with lots of geographic and regional differences.
Right.
And so, and this is particularly difficult with liver cancer patients, where that objective score called the MELD score, based on lab values, does not reflect the urgency of liver transplantation. And so we have long understood that patients with liver cancer have to be awarded exception points, points that are artificial in nature, but put them higher on the list. And the question is, where on that list do they belong? And over time, you've seen policy changes that may, quote unquote, over advantage liver cancer patients. So they're, transplanted in advance of patients who are arguably sicker based on underlying liver disease, and at times, quote unquote, disadvantaging our patients with liver cancer, placing them with too little priority. And so patients with liver cancer don't get enough organ availability. And I think what now we've started to see over time is that it's not so much about national sort of advantaging and disadvantaging. You've seen different areas where there's regional differences. In terms of some regions, patients with liver cancer are doing okay, and some regions where they're not getting enough not enough transplants. And recently there was a report that came out that, once again, there are regional differences in terms of where liver cancer patients are getting their liver transplants and their priority on this list. And so because of this, there now has been a mandate that we will revamp the system in terms of priority, and this will affect patients with liver cancer as well. We know that this change is coming down the pipeline. We don't currently understand exactly how this will play out because those changes are still being determined. But I think there will be continued progress in terms of finding the right priority for liver cancer patients on that transplant list.
Wow, thank you. That was such a great explanation. So Dr. Singal is going to stick around. If you have any questions for him, please put them in the Ask the Question area. I see 8 questions so far. That's amazing. And please upvote a question if you see it. So we're going to say goodbye to Dr. Singal, but he's going to be right back at the top of the hour. And we are going to bring Dr. Pillai on to the screen. And let's see, is Dr. Pillai here? I'm going to take a look, see if I can find her. Michelle, if you let me know in the chat if Dr. Pillai is here. If not, we will come back to her. I know she was standing by. So I'm going to go ahead and give Dr. Pillai's intro. Dr. Anjana Pillai is an associate professor of medicine at the University of Chicago Medicine and a board-certified gastroenterologist and transplant hepatologist who specializes in the management of chronic liver disease and hepatobiliary malignancies. Dr. Pillai is the medical director of the University of Chicago's Multidisciplinary Liver Program, the medical director of the Adult Living Donor Transplant Program, and the program director for the ACGME Accredited Transplant Hepatology Fellowship. And I have been notified that she is here now. Let me search by first name. There she is. Okay. We're going to invite Dr. Pillai up to the screen. And for the audience, we've got doctors from different parts of the U.S. It's pretty incredible, actually, from North Carolina, Minnesota, Chicago, Dallas. And so they represent a diverse part of the country. Here she is, Dr. Pillai. I already did your intro, so we're going to jump right in.
I heard it.
Did you always want to be a doctor?
I actually did. So I'm totally different from all the other responses. But I was born in a small village in southern India, and my dad was the only physician practicing in that area. And so my earliest memory is really kind of sitting on his lap over the weekends, and he would dispense medical treatment when he came from the city where he worked to the village. for people that couldn't afford it. So I always looked up to him. I just thought he was so cool, and people really appreciate it. So yeah, I actually don't ever remember wanting to be anything else.
Oh, well, why did you choose GI?
GI specific, so liver. Yeah,
Yeah.
so I actually wanted to be a trauma surgeon, which is very different from what I'm doing.
Very different.
But I really loved doing interventional things, and I loved my surgery rotations. And then I think I had an epiphany when I was actually really thinking about my career. At the time, there was really no real protected time or work hours. And I was like, well, there's other things that I also wanted for my life, and maybe trauma surgery was not ideal. So I was looking at other fields that really interested me. And I really switched to just GI, and specifically liver. I trained at the University of Miami as a medical student. And so they were already doing a lot of multivisceral organs. There's a gentleman, Dr. Eugene Schiff, who kind of wrote one of the seminal textbooks in hepatology. So there was a lot of kind of that influence. And then if you're a GI fellow and you're in that, in the GI, so you see all these cool interventions that they were doing. So, it just kind of fell that it seemed like a right fit for me.
And let's see, I'm trying to decide. Oh, something you said when we talked before. Why do you love the liver?
Oh, why do I love the liver? I love I love a challenge, and I love that other people get so frightened of the liver, right? I feel like a lot of people in the hospital, they get a liver patient, they're like, oh, it's a liver patient, physiology, they're so scared about everything. But I think, our patients, they have such varying etiologies of disease, such varying presentations. And, we really work and have to work as an interdisciplinary, multidisciplinary team to offer best care. You have to really understand physiology well. You have to really understand treatment options well. And you really have to build a long-term relationship with your patient. It's not just an outpatient thing. So it's all those things that I really love. And it's challenging, but it's very worth it. I oftentimes after transplant, our patients, are very thankful, and they'll say, and what can we do? Like, we're so thankful to you. And my answer truly is always the same. It's just, if you take care of yourself, and if you do really good by yourself and your family and your career, whatever it is that you have goals for, that really makes me feel like I've made a difference, and it makes me feel really good. I don't really need a lot of other, accolades for that. So that's why.
You mentioned your patients. You're in Chicago. What does your patient population look like?
So we're a big tertiary center. We're at the University of Chicago. So we have a huge, we draw patients really all over the Midwest, and really all over the US too. We also have international patients. And part of that is because in addition to liver cancer, we also have a program that does transplant oncology. And I saw some questions here earlier, which is transplanting patients that were traditionally looked at as contraindications to transplant. So intrahepatic cholangiocarcinoma, colorectal cancer to the liver, and certain other, more unique cancers that we have a program and protocols for. And I think patients often, when they hear of the, patients that have these cancers and hear of opportunities, they want to hear if they're a candidate for potential transplant. So that's why we, and I think most centers here, of all the docs that are represented, probably have that some, form of those levels of expertise in different areas that patients seek out.
Is your patient population just given the city that you're in, and then just, of course, the international patients you attract there, is it really diverse?
Mm-hmm. It is. We're in Hyde Park, so it's a diverse population where we are. But we also, we're a level 1 trauma center. We also, again, kind of feed from all over.
Okay. And I know in our pre-conversation, you taught me so much about the transplant program there at U Chicago. So how has the program evolved over time? And when did it begin?
So yeah, University of Chicago is actually one of the oldest transplant programs in the country. It did the first living donor transplant. It was a mom to a baby. So the first living donor transplant from an adult to a child, not an adult to adult. And that person is still alive and doing very well and thriving and off immunosuppression. And so it's always been a leader in innovation, but there were some bumps to our transplant program during the early 2000s due to some loss of key faculty. And we, since then, have created a transplant institute, and that happened in 2016. And that's when I joined as faculty from a previous institution. And so we've really, in the last 5-6 years, have I think we have 5 excellent centers in the city of Chicago. And I think we pride ourselves in being able to do kind of harder cases, out of the box cases, trying to be innovative, trying to provide care for maybe patients that would routinely be said no at other places. And we have grown in the last several years. Always when you restart or reimagine or reinvigorate a program, there's always takes a few years. And I would say in the last couple of years, we've had significant growth, and we continue to see that growth. And hopefully that will remain.
You mentioned living donor and you mentioned parent to child, but can you explain to everyone the difference between sort of what I think people think of when they think of transplantation and versus a living donor, and why that's possible with liver?
Yeah. So our liver is very cool. It regenerates. So not many organs do that, right? So a deceased donor transplant is what people historically know of, and it's called an orthotopic liver transplant because you take the liver from its current position and put it back in its same position, unlike a kidney transplant. You don't put the kidneys exactly where they are anatomically. So our deceased donor list is quite large, and we've talked about that. So thousands of people waiting, and although we've had a nice increase in organ donation the last few years and the most number of transplants that we've done, there's still a significant gap in supply and demand, if you will, between organs or between patients that are waiting on the list and organs available. So a living donor, either to a child or an adult, requires removing part of a healthy donor's liver. Usually it's a left lobe, which is a smaller area for a child, whereas and for adults, usually it's a right lobe, although a left lobe can be used. And the idea is if you pick the right donor and they are in good health and they're an anatomical match and no other issues, both the donor and recipient do very well. So you take that portion of the liver from a healthy donor, you give it to the recipient, and both the donor and recipient's liver regenerate to nearly their full size within 3 to 6 weeks. It's actually quite incredible.
That is incredible and opens up so many more options.
Absolutely.
We heard about Milan criteria. I think it was Dr. Singal who mentioned a MELD score. Could you, because there's so many things patients are juggling and they get to know this information, but what is a MELD score and how does that matter?
So the MELD score is the traditional MELD score is it stands for Model for End-Stage Liver Disease. It ranges from 6 to 40, and it included creatinine, INR, and bilirubin. And it's been modified in the last several years to also include sodium. So now it's a MELD sodium score, and there will also be incorporation. It's going to evolve a little bit more in the future. To a MELD 3.0, a slightly different score, but that's not currently happening yet. But so essentially, it's very objective numbers. You plug it in and you get a score. And the score ideally, for practical purposes, go from 6 to 40. The lower the score is, you would think you're clinically better. The higher the score is, the higher the chance of liver decompensation and death from liver disease. Now, there are certain patients that don't necessarily benefit from the MELD score because I said it's very objective. So things like ascites, variceal bleeding, hepatic encephalopathy, real things, frailty that affect patient quality of life are not incorporated into the MELD score. And the score has evolved. Previously, we used the Child-Pugh score for transplant, and that used both ascites and encephalopathy, but they're not objective measures, and people's measure of both those things could vary quite a bit. So we're trying, as Amit said about allocation, we're also trying to be as objective and as fair as we can with so many people on the list. But that's what the MELD score describes. But living donor really comes in when your MELD score really does not reflect how sick you are. So sometimes for cancer patients, like the transplant oncology patients that I discussed, they do not get extra points, different from the liver cancer patients. And then patients that really do have, these side effects of portal hypertension that are not brought into the MELD score.
Wow. It's so much to keep track of, I feel like, for everybody, right? It's so complicated. One more question before we go to our live Q&A. So if you are here with us live and you have a question, please put it in the Ask a Question box and upvote your questions, because we are going to start this panel in about 2 minutes. But I know you had a personal experience recently with your father-in-law, and I was wondering, whatever you're comfortable sharing, how has that experience changed the way you treat your patients?
Yeah, so my father-in-law underwent a double lung transplant in July, almost 2 years ago, in my alma mater. So where I was a fellow, a GI fellow. So it was
in Miami. Was that Miami?
No, I was a GI fellow in Cleveland Clinic. Miami was medical school. But, so that was really coming full circle, being someone very well-versed in transplant, being at a place I actually knew intimately well, because as GI fellows, we spend a lot of time in the hospital, and actually being in a place that I actually scoped many of, in units, which are surgery and CT surgery units. Like, you spend a lot of time scoping, doing endoscopic intervention. So, what it really, I've always really been very conscientious of making sure I spend time with my patients. Like I said, I really learned from my dad. I try to emulate him as well as I can, because he's still probably one of the best doctors I've ever seen. But I think what I really learned, and even though we all know this, but what I really learned as a personal experience is how important communication is. Because, this was during COVID. So my mother-in-law and I were the only two. You could only have 2 visitors, but not at the same time. And so we really relied on communication to each other for his progress, and also from the team. And so we would be, you can imagine, very meticulous in type A and writing down the plan and understanding the plan. And so when someone would not come, would be like, okay, today we need an ultrasound, or today we need a bronch. And that's going to tell us the changes in immunosuppression, or is he going to get better? He had a very rocky course. He was in the ICU for over 40 days. And then either people wouldn't show up or they wouldn't discuss the plan. And it was very, and I'm like, you spend your whole day waiting for a team to come, your whole day, for just give us 5 minutes of your time, so I know what to do with my loved one. So I take that experience with me all the time on rounds, and make sure that I sit down, and especially the first visit when you're in the hospital, make sure that patients feel cared for. I call the family if they want us to have a family member that's not available to be there with them, and I think it's really given me a deeper insight into what patients go through.
Yeah, there's a lot of waiting. There's a lot of waiting. It's no fault of the doctors, but there's a lot of waiting.
That's how it is. Yeah.
Oh, well, thank you so much for sharing that personal experience. So we are going to bring all of our doctors back to the stage. So Dr. Pillai, you're just going to hang tight here for a second. And we are going to start our Q&A, my favorite part. And let's see, I just invited Dr. Singal, I invited Dr. Moon, and I'm inviting Dr. Olson. And let's see, I think I did. Let's try that again. There we go. Okay. Fantastic. All right. Is there a way to minimize myself? I don't want to be part of the conversation as much, but okay. This is everyone's favorite time. It's our Q&A. We are going to the questions. please look at the questions right now and upvote your favorite one. And the one that has the most votes, we're going to start with. This is for anyone who wants to answer. What are the biggest challenges that HCC patients face today? Anybody?
I think I think there's lots of answers that can probably be for this one, and there's lots of unfortunate challenges, some unique to HCC, and some that I think Anjana just talked about in terms of medicine in general and navigating a very complex field. I think, Andrea, the thing that I've probably noticed, even in my relatively short time in the field, is we have a lot of progress, right? And so it's the type of thing where when many of us entered the field, HCC was relatively simple. We had sort of 5 treatments. And so you're okay, you can get this therapy, and that's really the only option. And it's been amazing because now you've heard about some of these advances. You've heard about some of these downstaging procedures. You've heard about sort of the expansion of eligibility. And I think it's interesting because even when you take a look at the treatment allocation systems, how you decide, many of the old allocation systems are now out the door. People this is far outdated. And it's become increasingly complex. And I think that's sometimes challenging for physicians, but that actually translates to challenges for patients. So you already mentioned, right? You're you need to make sure you're in the right center. Mm-hmm. And 100%, I think everyone here would agree, you need to be in the right center. But on the patient side, you're how do I figure out which is the right center?
Right.
How do I figure out who's the right doctor? You're and it's even more difficult when you're going through an acute situation because Anjana talked about her personal experience. I think many of us have had this. My dad was diagnosed with cancer, and I think it doesn't matter how good of a physician or how smart you are. When you have that, you become a base human being, and you start having panic, and you're how do I navigate this complex system?
Yeah.
And so I think that's the biggest challenge is how do you actually get into the right system? And I don't know if I have the answer because I don't think many of us have the answer, but I think the key thing is to find a system where you have all the doctors available, you have multidisciplinary care, so you at least have access to a team of physicians that will be talking to each other to find the right care. And the nice thing is it used to be who's next to me. I live in rural Texas, and so I have to go to the doctor that's down the street. But now with virtual visits, you have access to physicians anywhere in that state or even across the country. And so a lot of this can be done. And so I think it's the type of thing where find the best system. And then even if it's a virtual visit, make sure you get that second opinion if you want a second opinion or first opinion, but go to the best doctor, not the closest doctor.
And always get a second opinion. I just want to throw that in.
I was just going to echo that. I agree with everything Amit said. But one thing that I always tell patients is you don't have to stay with me. There's 5 centers, in Chicago. So I understand how hard it is. But if your doctor tells you or gets annoyed at the fact that you are going for a second opinion, there is a problem there, And I always say, I said, listen, this is my opinion. This is why I'm telling you, this is our practice. I try to incorporate evidence. I want you to be comfortable. This is not an easy decision. And I said, these are people I trust. And I actually do give names, because I think I feel like we're all doing the right thing. The end point is excellent patient outcome, right? Yeah. So you need to be with someone, but I can't emphasize that more. If your doctor is upset at those questions, you have to then, the answer. You got to find someone.
I tell patients to run. Yeah. If your doctor is personally offended, then you should probably run. Dr. Olson, Dr. Moon, anything you want to add about some challenges that you see today?
Go ahead, Dr. Olson.
You can go first.
Okay. I just wanted to piggyback on what Dr. Singal and Pillai said. I totally agree with all of that. I'm really glad that we have things like virtual visits available. That has decreased the amount of barriers. It's still challenging though. So I have patients in North Carolina. We see patients from all 100 counties at UNC, and it's people from the foothills of the Appalachians all the way to the Outer Banks, and they're traveling 5 hours. And it's great for them to be able to come into a multidisciplinary clinic and see everybody. But that travel for a visit, the travel for the procedure, the costs of the medicines. It's a huge issue for a lot of my patients. And even though those who really want a virtual visit, access to broadband is an issue. And then telephone visits aren't reimbursed at the same rate that a video visit is. So I'm glad that, the silver lining of COVID is that we had an explosion in virtual care. But I think we could still do a lot more to kind of take down these barriers.
Okay. Anything else to add, Dr. Olson,
Yeah,
before we move on? Go
I
ahead.
think one other challenge for patients with hepatocellular carcinoma is that the care plan isn't always linear, and so what may start out as a plan may change. And to everybody else on the panel's point, when your physician will spend time with you and answer questions, it helps them navigate what can be a complex disease that is not always straightforward in how it manages. You may start with one plan, but because the disease progresses or responds better than you think, you may have a different plan in a couple of months. But again, none of us would ever be offended by having somebody get a second opinion. Pretty quick if your team is spending time with you and answering your questions, that should give you confidence in the care that they're going to deliver for you.
Andrew, can I add one thing just really quickly?
Yeah.
So actually a couple things. The first is brand name doesn't always mean
so true.
Because HCC is somewhat a niche disease. Even though it's so common, it's the type of thing where you have to have different expertise than other cancer treatments. And so I think you really need to know what is the good liver cancer center versus just a broad cancer center. And you can have a very good medical oncologist that is excellent for 900 other cancers, but is not a good liver cancer doctor. And so I'm going to put Blue Fairy on the spot here in terms of Blue Fairy actually can help connect you with a good doctor. So this is one of the many things that Blue Fairy does is they can actually help connect you with different specialists across the entire country. And so I think that it's important to know who has liver cancer expertise. And to Dr. Olson's point, I think it's important, particularly, we already talked about transplant. It was one of the big things that we talked about today. So if you're found at an early stage, make sure you take advantage of that early stage. It's so many people are found at more advanced stages and don't have surgical therapies available. And once again, I think you heard a couple times the frustration and the sadness that all of us feel when somebody was transplantable and they missed the window, because that's what it is.
It's a window.
Whether that's at presentation or whether that's because you responded to therapy and a new window opened, if you have that window, make sure that somebody is thinking about transplant. It's the cure for liver cancer and cirrhosis. And it's not a window that stays open for years. It's a window that stays open for a time, and then unfortunately it closes. And once it's closed, it's hard to reopen.
Yeah. Oh gosh, we have so many questions to get through. Okay, so how often is HCC diagnosed in patients with non-cirrhotic portal hypertension and portal vein thrombosis? And this is from Teresa. And Dr. Singal, you already answered this. I love it. I'm just going to read it. And if anyone wants to add, Dr. Singal said, over 90% of patients with HCC develop in cirrhosis, and the risk of HCC in patients with non-cirrhotic portal hypertension is very low. Anyone else want to add to that?
That's the answer.
That's the answer? All right, there you go, Teresa. You got it answered. Let's see. We have another one. Oh, Dr. Singal was just busy here in the questions. Oh my goodness.
Getting extra credit there.
I love it. Here's one. I'm not sure of the question, so we might invite this user on the screen, but she's giving us a very broad question. She's at the point with HCC that she needs to try new options or go for quality of life. She was diagnosed 2 years ago, and I'm saying she, it could be he. She's had surgery, immunotherapy, a drug trial, and more, but nothing has stopped the cancer. I'm a healthy person otherwise. My labs are good. And this is so confusing. Oh, here's the question. How is it that all my labs are healthy and good, and yet my tumor is filled with very many aggressive livers? Anybody want to take that?
I think that's really frustrating. And unfortunately, we see that a lot. Your liver, sometimes you look at people, not sometimes, often, and they look great. Their performance status is great. They're still working, and their liver doesn't look so great, and I think that is a very frustrating situation that I really empathize with. I would say, as we talked about before, if all your treatments were done at the same hospital, this would be a good time to look for a second opinion.
Yeah.
And just meet other, it can hurt. You have virtual options. You don't need to necessarily go to each institution just to see. So for yourself, okay, this might be where I'm at. Because I think that will help a lot of people, and you specifically, think about what's important to you. If you feel well, then you can really focus on keeping the cancer just hopefully stable with therapy you're on, and focus on quality of life, factors that I think that's the only real way to do that. I don't know if I want to add to that.
Yeah, I mean, I agree with Anjana. So, I think this is a great point, in terms of this is a great time to at least get a second opinion, just make sure that nothing was missed. But it sounds like at least the entire spectrum of care was considered, right? So considering surgery, considering systemic therapies, clinical trial, which is, there's so many good clinical trials out there right now that it's a good option to consider. But I agree. It's a very frustrating situation where you've tried multiple good therapies and the cancer just appears to be fairly aggressive. The silver lining, I would say here, is that the liver function is good, that it sounds like the performance status is good, that these other factors are still strong. And it's such an important time in the liver cancer field because we have more and more therapies available. And just because the therapies that have been tried have not worked, we do see rescues for latter lines of therapy. So
what does that mean?
Yeah, you will see people fail or progress on a certain drug and then try a subsequent drug. And there are a portion of people who will have responses. There's a portion of people who have prolonged stability. And, then there are some that progress. But just because the prior drugs failed does not mean you should assume that subsequent drugs that are available in the field will fail. These all have different mechanisms that they try. And so the good thing is that we have lots of drugs in our tool belt now, lots of different options. And so I don't think this is time to give up hope. This is time to say, okay, I need to sort of, of course, it's frustrating, and but a little bit of a deep breath and say, I'm going to come into round two. And round two is going to be different than round one.
Okay. All right. We have so many more. Let's see. I'm going to let you start this next one, Dr. Moon. Are the protocols for cancer recurrence for breast cancer the same as liver cancer? So do all cancers begin from inflammation?
So to answer the first question, the short answer is no, they're different. Post-treatment breast cancer surveillance strategies include mammography, for instance. They do have some of the same staging scans that liver cancer patients receive, but patients with liver cancer will receive MRIs or CTs immediately after treatment, usually around every 3 months, every 3 to 6 months. Oftentimes, imaging of the pelvis as well, a little less frequently, and then CAT scans of the chest. And that's basically based on the most common places that liver cancer spreads to, which is
I'm sorry to cut you off. I'm just aware of the time. What about cancer beginning from inflammation?
Yeah. So a lot of cancer does begin from inflammation. So, in the case of liver cancer, viral hepatitis, non-alcoholic steatohepatitis, alcohol-associated steatohepatitis, it all includes hepatitis or inflammation of the liver.
Right.
That damage to the cells, the regrowth of the cells may lead to DNA damages that can basically result in the formation of cancer cells that grow out of control. There are a lot of different things that can kind of contribute to cancer development, radiation, DNA damage, things like that. But many different types of cancers, including liver cancer, can result from inflammation.
Okay, thank you.
Yeah.
All right, so this, Dr. Olson, I'm going to give this to you because it's a very interesting question. And I'll preface it with the very, very first patient Blue Fairy ever helped was a patient with secondary liver cancer. And so this person's question is, has a diagnosis of colon cancer that has metastasized to his liver. And what he wanted to know was, does this event still apply to his condition? I'm going to rephrase it a little bit, Dr. Olson. Are the therapies that are used for HCC commonly used for secondary liver cancer?
Yes, there can be considerable overlap between some of the therapies we use for our primary liver cancer, like hepatocellular carcinoma, and what we use to treat metastatic disease to the liver. So, for example, colorectal cancer with small metastasis to the liver can be surgically resected, which is something we use in HCC. Ablative therapies can also be used. So there are there's some similar approaches to especially isolated liver metastasis that can be seen across both disease types. Interestingly, there's also early exploration for considering liver transplantation for patients with isolated colorectal mets to the liver from colorectal cancer. So you may be seeing more of that in the future.
I just want to do a shout out. I know a patient right now who survived colorectal cancer, got metastases in his liver, was put on the transplant list, has been on it, I think, 18 months, and is getting the transplant from a live donor next week.
Yes.
So I'm
So
really, really excited for him.
That is something that you'll probably see more of over the next few years. And there are several other, it really depends on the cancer type. For example, things like neuroendocrine tumors, liver transplant has been used in this field, but it's somewhat specific to the type of disease as well as if there's other extrahepatic disease.
Thank you. And these doctors are so amazing. I don't know if you guys realize, if you look in the questions, they're answering them. Just in case we can't get to your questions, they are answering them. So thank you so, so much. And if you post a question in the chat, be sure to put it in the question. So LaShonda, I put your question into your chat, your message in the chat into the question, and you're already receiving answers. I want to ask this of all of you, if you give me like 1 or 2 sentences, because it's the theme here. What is your concept of a team, and how does a multidisciplinary team function at your particular treatment center? And let's go back to Dr. Pillai.
I was just answering a colon cancer question too. But, I just wanted to tell Dan that we have a protocol for that for our center. So if he wants more information, but the primary colon cancer has to be removed for all these, for transplant to be considered. As far as the team, yes. So as Amit said, I think it depends on who is kind of leading the team. I think that really kind of sets the vibe for the whole, multidisciplinary interaction. So for us, we did not have a liver cancer program until I started in 2016. And
wow.
so
I didn't know that.
I know. Well, like I said, we had to revamp we had to change, we had a reinvigoration of our program. I don't know what the words are, but so, it was nice in a sense because I could really find the people that were most interested in liver cancer, and we grew together so that not one person's voice would only be heard. And I think sometimes with like traditional teams that have lasted for a long time, sometimes it's the most senior member, sometimes it's a surgeon, sometimes it's an interventional radiologist, sometimes it's an oncologist. So I am, I take the lead for our team in the sense that I direct it, but that doesn't mean I make all the decisions by any means. But I try to, on tumor board and during our clinic visits, really make sure that we've thought through all of the questions and all of the options for treatment. And the other thing is I actually reach out to my friends. Some of my closest personal friends happen to be cancer specialists. So we have a group text that, that's what I'm saying. If there's a complicated patient case, I actually want to know what other experts would do because there's not a clear answer. So I try to bring all that into, my patient interactions. And so I think a team really has to be a team, not just saying you have a team, but really multiple people with multiple expertise who are staying on top of the field, which is now really changing, and have a real interest in it.
Dr. Moon, what about you? What is your concept of a team?
Yeah, I totally agree with everything Dr. Pillai said. I find our multidisciplinary HCC clinic to be one of the most rewarding experiences I have in my week, just because it's so fun to discuss with the oncologist, the interventional radiologist, the radiation oncologist, go through all the options and all the questions that the patient has to come up with the best treatment plan for each specific patient. The other thing I'll mention, in addition to the physicians and the advanced practice providers, is the nurses and the nurse navigators play a huge role on the team. So the nurse navigators are often the primary point of contact for a lot of our patients and help navigate some of the logistic obstacles I brought up before, as far as travel, as far as setting up lodging before a treatment, as far as dealing with any symptoms that arise for the patient. So that they're a really key part of the team.
I would also add, because I feel like they get left out, pharmacists. Pharmacists
100%.
often catch, those contraindications and issues with multiple medications at one time that a doctor might not necessarily see. But the pharmacist has that laundry list of medications that the patient is currently on. And so they are part of that team as well. I'm going to cut that one a little short. Dr. Olson, we are going to go to you for this very last question. And then we'll kind of go in reverse alphabetical order, I think. We'll see. So I think this is really special and important for people to hear. Which HCC patient have you remembered the most during your career, and why? So Dr. Olson, you first.
I think, like everybody else on this panel, I love taking care of my patients, and I remember, I think, all of my advanced liver disease patients and liver cancer patients. Early in my career, and when I first started managing HCC, I had a patient that had a really advanced stage presentation. Did not think we were going to have a very successful outcome. We were still in the day when treatments were fairly limited, and by stroke of good luck and with emerging therapies, we were able to, extend his life for 4 years, beyond what we would have expected based on his initial Caesar presentation. I got to know his family well. His daughter was in high school when I first met them. She went on to become a respiratory therapist in our hospital, and so I was able to keep ties with the family even after he lost his battle. But we all love our patients, and I think every HCC patient that I see is special to me.
Okay, and I did say reverse alphabetical order, but by first name, which is a little tricky here since we have 3 doctors whose names start with A, but I did it in my head. And Dr. Pillai, which HCC patient if you remember the most?
Like, am I next? I'm like perplexed about this order more than the question. So, I completely agree with what Dr. Olson said. I think of several patients always stand out in my head. One, actually, the HCC patient was when I was probably just really right out of fellowship, was a patient when one of the previous centers I was in Chicago, was told he had multifocal liver cancer and was not a transplant candidate. And so he, comes to this clinic and he sees me and he's like, "Have you been practicing long?" I'm like, "Yeah, I've trained for like 8 years, but you might be like my second patient." But I was like, I really think that you can get a transplant, And he was just like, well, no one actually told me that. But he did. He fit criteria, and it was multifocal, but it was within criteria, and I think, and he was on sorafenib. He was on the only drug, that we had at the time. And so he did get transplanted. He did very well. I did lose touch with him because I had left Chicago for a brief stint down south, but I still have a picture in my office that he drew me, which was, I'm like Superwoman and I'm holding, I think it's supposed to be the liver, but it looks like a heart actually. So I made him done the best educating him on like,
the liver does kind of look like a heart.
Yeah, my pictures, but I still have it. I keep it because it sometimes reminds me when like people look at me and they're like, do you know what you're talking about? Like, he really gave me that trust. Like he was kind of, like half serious, but half kidding maybe.
Right. Oh, I love that. Dr. Moon, what about you?
Yeah, so I have a patient who came to me. He was in his 80s, and
Wow.
he actually came into the emergency room, had no idea he had liver disease, came in with abdominal pain, and he had a ruptured HCC. So he got a bland embolization to stop the bleeding, and then we talked about his case and talked about whether he could receive a resection for his HCC. And that's what we discussed as an option. The surgeons were a little nervous about an 80-plus-year-old, but I said, he was a guy walking the halls, doing stair steps on the wards type of thing, very fit guy. Once they saw him, they agreed, and we did resection. I told the patient, we're doing a resection, but the risk of recurrence is going to be really high, particularly because you had a ruptured HCC. And sure enough, a few months down the road, he had metastases to the lungs. And he was really worried and wanted to ask a lot about prognosis, and also wanted to ask how his treatment may fit in with trips to Europe and maintaining quality of life.
I love it.
Checking off his bucket list. And so we talked about treatment options. We decided upon immunotherapy, but he was like, I'm due for my infusion this week, but I'm going to be away. I'm going to be, with family in Europe. So we're going to push it back a week and this sort of thing. He always kept an eye on, all the things he wanted to do outside the hospital. So I saw him a couple of weeks ago. He's now a year plus out from starting treatment with no signs of disease. And,
what?
Yeah. So it was really rewarding to see the smile on his face with that incredible treatment response, but also hear about, all the trips he had recently taken and all his future plans.
Oh, wow. It's so great that he has no evidence of disease. All right, Dr. Singal, to you.
Yeah, I think, Andrea, good job in terms of keeping me last, since I tend to probably be the most verbose sort of.
It was intentional.
I think that was the order. I think that was why, but I think it's a good idea. I think I've probably been doing this long enough where I feel like now there's I could come up with a list. I could probably fill an hour-long sort of, talk on sort of all these patients that I remember and stick with me. And I think some of them are because they were quote unquote wins, and some of them, cut deep because they were quote unquote losses where I, felt like we could have or should have probably done better, or wish that we could have done better. But I think the patient that sticks with me offhand is one where it was a combination of wins and losses. And to me, I always think that it highlights that even though you may lose the battle one day, you can still win the war. And so this is a constantly evolving sort of disease over time. And so it was a patient who started with a very small liver cancer. And the idea was that he wanted to get to transplant. So he needed to have it be above 2 centimeters, complex concept, which probably needs more time to explain. But he unfortunately went from having a 1 centimeter or 1.5 centimeter tumor to then having vascular invasion. So it went from, very small to invading a blood vessel very quickly within 3 months. And so, we know that there's a small risk of this happening, but we did not think it was going to happen in this case. And we, of course, had that discussion with him when we went through the strategy. And so I remember feeling very down that day leaving clinic. And, I think that that weighed on me. But we had treatment options, right? I mean, so we treated him with the radioembolization. Once again, that therapy with radiation into the liver, and the tumor responded very well. And so it came out of the vein. The tumor actually had a great response, and we were able to get him listed for transplant, and he subsequently underwent transplant. Wow. And so, like, for me, that is, once again, this idea of just because something goes bad, don't give up hope. Like, sort of take a deep breath, regroup, figure out what the best strategy is at that point, and always continue to try to get people to curative therapy whenever possible. And so, and he's doing amazing. I mean, he, once again, like many of the patients you heard, is now 4 or 5 years post-transplant, amazing quality of life, living to see his kids and his grandkids. And so, like, I think it's just the type of thing where it's such a crazy disease. And so I think, but the nice thing is the fact that, like, all of us have these patients that we carry around with us, I think makes us better.
Yeah. Yeah. Oh, thank you so much for that. I know we did not get to every question live in terms of me saying it, but I see that the doctors have responded to all of the questions. So please give a big, big round virtual applause to Dr. Pillai, Dr. Singal, Dr. Moon, and Dr. Olson. And we have one last poll that we're going to leave up here. How much has your knowledge about HCC and what HCC providers and what they do increased on a scale of 1 to 4? 1 meaning you didn't learn anything new. 2, you learned at least one new fact. 3, you learned several new facts. And 4, you learned a lot of new facts. And we will leave that poll up even for the replay. Again, thank you so much, all of you, for your expertise and your time. I know it's a Saturday. I really appreciate you doing this. And for anyone in the audience, whether you're watching this live now or the replay, if you want to get in touch with any of these doctors, my email is in the chat. You can see that Michelle posted it. It's Andrea, just my name, at blueferry, BLUEFAERY.org. So that is in the chat. Please reach out to me. And if you want an introduction to any of these physicians, I would be happy to do so. But we're going to protect their emails and not put them in the chat. So just reach out to me. Again, thank you everyone for coming today. Thank you to all these amazing, amazing doctors. And if you want to see part 2 of this series on the multidisciplinary team, please join us on Saturday, June 24th at the same time, 12 p.m. Eastern, to meet the medical oncologist who manage HCC. And if you want to be notified, just click that green button at the bottom, follow Blue Fairy on Crowdcast for all of our live events. We will give you the rest of your day back. Thank you so much, everyone. We really appreciate it.
Yeah.
Thank you.
Bye-bye.